All right, we're at the top of the hour here. So it's my pleasure to introduce Richard Powers, our chair for this event. Richard, why don't you take it away?
Thanks, Maurice. Thanks, everyone, for joining us today. We have a great panel. We're going to talk about COVID-19, the new role of chronic disease management tools in the fight of COVID-19. But before we get started, I want to give some general instructions about the format of the discussion. We're going to have, at about halfway through, we're going to have a Q&A, or excuse me, an audience poll that we would ask everyone to participate in. We've got some questions for you all. And at the end, we'll have some audience questions, some Q&A. And during the discussion, if you have questions, there's a Q&A button as part of the Zoom meeting. If you hit the Q&A, you can enter your question there. And we'll be collecting those questions for the Q&A section at the end, sort of after the discussion. So if something comes up you want to talk about, pop a question in the Q&A section. We'll try to get to it at the end. And I'd like to start off by thanking the event committee. There's a lot of folks here: Joe, Brian, Jim, Lynn, Seth, Sveta, Maurice. Big help, Maurice, on the Zoom. Thank you very much. And Rebecca with TAG. So this team has done a great job of putting together a fantastic panel that's going to be really interesting, and getting this all put together. And of course, we wouldn't be able to do this without our great sponsors. And I'm going to have each of the sponsors, I'm going to give them a minute to tell you about themselves and their company and what they do. Let's start off with Bill Bradley with Teliant.
Yes, thank you. Good afternoon, everybody. My name is Bill Brady with Teliant Systems, and I'm the client manager. We're a product engineering and custom software development services company based in Alpharetta. We're proudly celebrating our 10-year anniversary this year, and we're also very excited to be a TAG Digital Health sponsor for 2020. We partner with small and large technology companies in healthcare, financial services, and several other verticals, and have expertise in a broad range of technologies, building mobile, cloud, and embedded software solutions from concept all the way through implementation. We could also provide ongoing support and maintenance. Specifically in healthcare, we have experience building telemedicine applications, building integrations into EHRs, and building health informatic dashboards and analytic platforms. I'd certainly be open to a discussion with you. My contact information is up on the screen, so feel free to reach out to me at any time. And thank you. With that, I'll hand it back.
Thanks, Bill. Our next sponsor is Azalea Health, and we had Fahad Salim.
Hi, all. Thank you. My name is Fahad Salim. I'm the Vice President of Client Services here at Azalea Health. Azalea is a Georgia-based company founded in 2008 in Valdosta, Georgia, by three co-founders who are, to this day, core members and part of the senior management team here at Azalea, including our CEO, Baha Zidan. Azalea provides an EHR platform, an enterprise SaaS-based EHR platform for independent physicians as well as hospitals. We're one of 8 EHR platforms in the country that provide services on both the ambulatory side and the acute side. In addition to that, we also have an RCM wing to our business where we do end-to-end billing, starting with claim generation all the way to appeals and denials with payers for our clients. We've been offering a lot of services in response to COVID-19, but the 3 I'd like to highlight are additional help on the RCM side, specifically around telehealth and how to bill those visits. We've been providing a lot of regulatory help from a clinical and financial perspective to our clients. And then one of the biggest ones is offering our telehealth module and services to our clients as well. So therefore, if you have any questions about Azalea Health or any of the services we're providing, please feel free to reach out to me. Thank you.
Thanks, Fahad. Next sponsor is Kennesaw State, and here to talk about that is Sveta.
Thanks, Richard. This is Shweta. I am leading the healthcare management and informatics program at Kennesaw State University. This is the only program of its kind. It's completely interdisciplinary, sitting at the Coates College of Business, but cutting across 5 other colleges at Kennesaw State. We have partnered with multiple organizations, and many of you sit on our board. The organizations that we partner with, we are very heavily engaged in conducting research, and if you're interested in being partnership in partnership with us on and serving us on our board members, please reach out to me. I think my information is on the screen as well. So looking forward to hearing from you. And I think 10 or 12 of our students are also on the panel, not on the panel, but on the session today. Thanks, Richard. And back to you.
Thanks, Shweta. And last but not least, we have Integra Connect. And here to tell us about Integra Connect is Jennifer Webster.
Hi, thank you guys so much for inviting me today. I'm Jennifer Webster. I'm VP of Analytics for our Population Health Division at Integra Connect. Integra sits at the intersection of value-based care and precision medicine. And we have a suite of solutions mainly aimed at specialty practices, specifically at oncology practices, that help navigate kind of the new value-based care world, but also leveraging big data, genomics, socioeconomic data, EHR data, et cetera. So we have an electronic health record, a full suite of population health management and analytics tools, and then we do pretty significant RCM, revenue cycle management as well. We are based out of West Palm Beach, Florida, but our technology offices are here in Alpharetta.
Excellent. Thank you, Jennifer.
Thank you.
So I'd like to start off with having our panelists. We have a great panel today. Matt Ethington with Chronic Care IQ, Lucy Eyde with Remedy, Steve Liu with Ingenious Med. He's actually out at Scripps practicing out there as well. And Jane Morgan with Piedmont Healthcare. And let's start out with Matt. Can you tell us about yourself?
Sure. My name is Matt Ethington. I am the founder and CEO of Chronic Care IQ. We are a technology platform that sits on top of any EHR, allows doctors' offices and service lines to provide comprehensive remote patient care.
Great. Okay. Next, Lucy.
Hi, good morning. This is Lucy Eyde. I'm founder of Remedy. So by background, I'm a clinician and technologist, and started Remedy a number of years ago, really focused on this core issue of how do we create a continuous model of chronic disease management, which inherently meant, remote patient monitoring and extending care outside of the healthcare system. So we are also the software platform technology that works across electronic health record platforms and across disease states to support that goal of, optimizing outcomes for patients and efficiency for healthcare providers. So glad to be here today and talk about our overlap of our work on chronic disease and what we've been doing on COVID.
Thank you, Lucy. Steve.
Steve Liu, founder, CMO of Ingenious Med. As you mentioned, Richard, I'm intensivist practicing in the ICU as well in my part-time setting. All the COVID patients do go through our group, and so intubations, pronations, thankfully extubations are all sort of happening, in the thick of it. The company Ingenious Med, it's a point-of-care physician platform. It's used in the acute and subacute setting. Really kind of focusing the physicians on maximizing revenue, which has become sort of a big hot button. It's always been a hot button, but even more so in sort of these times, as well as managing physician performance. And then if you've done value-based goals, we align the physicians on that. Maybe I'll just kind of close my part with just we're in about 80% of the largest health systems and national physician management companies. And so about 20% of the nation's hospitalized patients go through our platform, which gives us a really neat insight into kind of what's happening, especially in this case with COVID and sort of hospital trends. So thanks for having me. Looking forward to the conversation.
Thanks, Steve. And last but definitely not least, Jane Morgan.
Hello, I'm Jane Morgan, and like many of my other panelists, I'm also a physician by training. I'm a cardiologist. I currently lead the Office of Innovation at Piedmont Healthcare. Within that role, We are really seeking to be the leaders in healthcare in developing tools for not only chronic disease management, but to optimize healthcare for all of our patients, especially as it relates to quality and safety. I've probably spent the last 15 or 20 years in research at Abbott and Solvay before coming to Piedmont. And my passion really lies within the research realm and within innovation and development. So I'm pleased to be here today.
Thank you, Jane. And so I'll introduce myself. My name is Richard Powers. I'm co-founder and CIO, COO of a startup. That's why you can have the /C's in a startup called Strados Labs. We have developed a timely technology. It's a remote monitoring system for respiratory. So a remote respiratory monitoring system. We've just submitted that to the FDA. We've submitted our 510K. And I am here to learn from these panelists today. We've had some great pre-event discussions, and I'm really looking forward to this discussion today. So I'll start off by saying thank you all for joining us here today as we discuss the new role of chronic disease management tools in fighting COVID-19. So we're all acutely aware of some of the impacts of COVID-19. In fact, the fact that we're having this meeting virtually versus in person is an obvious one, first of all. But what we'd like to explore here today is the impact that COVID-19 is having on the context in which chronic disease management tools are deployed and utilized. And this context shift will fundamentally change the future of healthcare. And our exploration, our discussion today, we'll explore this tool set, and we're going to define that loosely. We're going to include telemedicine and digital health tools as they're commonly in the provider tool set for managing these patients. So we didn't want to limit the conversation today. We wanted this to be an engaging and timely discussion. So we're going to explore a bit more broadly than sticking exclusively with the tools themselves, because I think there's a lot of interesting things that are happening that we want to explore. So we have a panel of esteemed experts here that just introduced themselves that will provide multiple boots on the ground perspectives into this swiftly evolving, and by swiftly, a day feels like a week and a week feels like a month, swiftly evolving landscape that COVID-19 is shaping. So they're going to provide different perspectives. As you heard, they have different backgrounds, clinical provider, technology provider, and even patient, as you'll see. So I'm going to start off, everyone's already introduced themselves, so I'm going to start off with kind of setting the stage for this discussion and kind of getting some background and seeing what's going on out there. So let's start off by asking, we're going to start with Jane first and Steve. What has been your experience with COVID-19 patient hospital utilization? Did you get to capacity? What are you seeing now? What's the curve, if you will, look like? Jane, what are you seeing?
Well, early on in this, we certainly began to slow down our procedures to push all of our PPE to the front lines as we were watching the modeling curves and where we were expecting to reach our peak. And so that certainly impacted all of our elective procedures, certainly impacted specialists. And so, that has gone on really through the month of April. As it turns out, our peak was probably somewhere in the first or second week of April. And where we're finding ourselves now is beginning to develop a recovery mode. How do we begin to get patients back into the hospital? We've certainly had a large volume of COVID patients. We're seeing that steadily decline. We are reopening our operating rooms, and what does that look like in this new era of COVID-19? Which means currently we are testing all patients and their companions before they come into the facility, and only those who test COVID negative can then come in for their procedures. That testing is taking place outside of the hospital within cars, and patients are held there until the results are back within 15 or 20 minutes. And so I think as we continue to move through this era of COVID-19 with the gradual reopening of our states, we're trying to find out what is that balance between patient care, keeping our staff safe as well, and continuing to move on with really the bread and butter of what the hospital is, which is managing patients who need the care.
Great. Thanks, Jane. How about you, Steve? What have you seen out west?
Yep, I'm going to unplug this fax machine, which is making noise on the Zoom call. It's interesting in that we get real-time data from our clients. Our clients use it to kind of manage their hospital volumes and their practice volumes, and so it jives a lot with what Jane you've sort of seen over there at Piedmont. In terms of the COVID admissions, you saw them sort of climb, and we've had pockets. A lot of our clients have had just really bad locations. So like New York, New Jersey, Florida, where volumes have gone 5 times normal, and they've been hit really hard. But I'd say across the nation, it's been more of a I call it a rising tide, sort of slow rise, nothing close to the New York tsunami as a general kind of population. And to Jane, your point, I think we're seeing sort of the same thing where COVID admissions into the hospital probably did peak around 3 weeks ago. If you follow the data, probably on a weekly basis, you can see sort of a slight decline. So I think volumes of COVID patients have declined by about 25%. Is what I'm seeing. Who knows, if there's going to be wavelets or double peaks or triple peaks, probably. But that's sort of what the general look looks like. In terms of the hospital volumes, it's fascinating because if you generally kind of look at January, that's usually where hospitals have sort of their glut of patients. That's the winter spike. And once COVID hit, it absolutely plummeted. I think the nadir was right around January, where volumes were probably 60% of what a normal hospital volume is. And what's actually been fascinating is there's been a recent J point. I think probably over the past maybe 2 weeks, you've actually sort of seen a little bit of a reboot, a little bit of a rebound. I think volumes are maybe now at 70% of normal May volumes. And that may be from quarantine patients getting tired of being at home and feeling more okay with going into the hospital. You probably have patients who are really sick that have been avoiding it and now are just too sick to stay at home and making it in. And that's what we're seeing. We're seeing people who do come in are pretty sick.
Thanks, Steve. And that's a great segue. Speaking of that J curve, there's been some speculation that people are deferring care. So folks are afraid of getting exposed. So if they have some event, if they have some symptom that's non-COVID related for a heart attack or stroke type symptom or appendicitis, things like that, people are putting that off and deferring care. Let's go back to Jane. And what are you seeing on that front? You guys, you mentioned the hospital utilization. Are you seeing deferrals of care and later presentations?
So certainly we're seeing that, and those are some of the priority patients that are being brought in. I think not only at Piedmont, but across the nation. Those elective surgeries that have been delayed, some of those patients, as you can imagine, have now shifted from elective to essential. So their conditions have worsened and are really a little bit more acute than elective surgeries. And so we're starting to contact those patients and bring those patients in first. I think when we look at, what is the rate of stroke, what is the rate of MIs, heart attacks, it shows that during the era of COVID-19 that we are passing through now, the data shows that there have been fewer heart attacks and fewer strokes. But what we're also seeing is that there have been twice the number of at-home deaths, and what those deaths are related to is unclear. So there's a debate, I guess, raging within the medical community regarding whether the decrease in heart attacks and strokes is due to an overdiagnosis in our society and within our discipline of heart attacks and strokes, or if these are patients who otherwise would have sought medical care and have quietly died at home and have gone beneath the radar. And so that's something that, that we will need to sort of tweeze out as we continue to move into what our new normal looks like within this COVID era.
That's interesting. Steve, have you seen similar?
Yeah. And it's funny. I was kind of just thinking about COVID, before months ago and as of today. I mean, it's a weird world. It's a bizarre world, in my opinion. Where I walk through the ER and it's half full, and if you had chatted with me, a few months ago, I mean, my typical conversation for patients would be, you're not that sick. We fixed everything. You can go home. And a lot of patients wouldn't want to go home. And now you've got people leaving AMA from the ER, not wanting to come in. And actually, once they do feel a little bit better, even when they're not ready to go home, they want to go home. And so maybe the good thing about it is I think the hospitals are now filled with sort of these sick patients, the people who really do need to be in there. And there probably were some patients who didn't need to be in the hospital. COVID's such a weird, there's good and bad with it. Obviously, a lot of bad, but there's interesting parts to it. Yes, the hospital is filled with the more sicker patients, but the other extreme is the people who do need to get in aren't. Like I was on a telemed call for myself with my PCP, and he was late. And he was actually late because he was on the phone with a patient, or actually telemedicing with a patient who had spent the weekend with, ischemic symptoms, heart symptoms, probably having a heart attack, and convincing him, no, you have to go in. And, this poor guy probably will end up with, some irreversible damage and lifelong, costly, quality and clinical consequences. And so to Jane's point, I do wonder about the patients who are deferring care and having untoward outcomes.
Yeah, that's interesting, and we'll see that as the data comes out and as the curve starts to tail off and people do the other side of that J curve comes in. It'll be interesting to see what the effect of that is, and as we look back and see the mortality throughout the year, what that curve looks like. So shifting sort of a little bit from the clinical setting, the stage, to some of the other areas, for example, regulatory loosening. I know I've been following very closely. The FDA has put out numerous emergency use authorizations and multiple guidances regarding technologies and testing for COVID-19. For example, I know we were really interested to see a piece of guidance that said that these remote monitoring technologies that may have initially been cleared for inpatient use can be used in the patient's homes. That's okay for now. So Lucy, can you give some further examples of this and how this impacts these tools getting into the hands of people who need them more quickly?
Sure. I mean, the amount of regulatory and statutory change over the past couple of months has really been astounding. And it's one of the areas where I think the federal government has done a great job of moving quickly, whether it was done, legislatively through the CARES Act or directly by HHS. So to your example, right, there are cases where the FDA is allowing for home use of inpatient technologies, vice versa. They're allowing for hospital-based use of home technologies like blood glucose monitoring, in line with trying to limit contact of how many times does that nurse have to go into the patient room and potentially be exposed and carry that to other people. So if patients can use their connected glucometer at their hospital bed and upload that data, and that saves a nurse or a tech from having to go in and take their blood glucose, right? That's a pretty easy win. Some of the other sort of meaningful regulatory changes, I would say, around HIPAA has been one. So there's sort of enforcement discretion around HIPAA that's allowing all of this sort of instant shift to telemedicine and remote monitoring to use what might not be HIPAA compliant platforms like FaceTime or Zoom for this period of time during the public health emergency. Changes for telemedicine around originating site and destination site. So those who are familiar with telemedicine, and it used to be that the doctor or clinician originating the visit needed to be in a certain geography or a certain site within that geography, like an office. and the patient might have to actually be in the clinic, not at home. So they've now, now everyone's doing FaceTime, right? The doctor's at home, the patient's at home, and that's getting paid. So I do think they've done an exceptional job in this area. And, Medicare is now covering telehealth for federally qualified health centers and rural health clinics, which has been an ask for a very long time. And, there's a big push in what will be CARES 2.0 to make that permanent. So a lot of us are, taking these temporary gains and lobbying for them to become permanent changes.
Oh, yeah, I think that's starting to get at a pretty important theme that we're going to be revisiting throughout this discussion. So you hit on a really interesting topic of reimbursement. So there, like you mentioned, there have been some loosening of the reimbursement requirements. Matt, have you seen anything else on that front as far as reimbursement goes for telemedicine and these digital health technologies for these chronic care platforms?
Sure. And I think that the doctor spoke of them, rather succinctly. I'll give you a use case scenario. I'm originally from rural Nebraska, and I spent all my summers on farms in central Nebraska. If something happened to one of us or we needed to see a primary care doctor, we were 35 miles away. If we needed to see a specialist, we were at least 60 to 75 miles away. And if we needed a subspecialist, you could plan on that being 90 miles away. And and that's not all just on emergent conditions, that's on managing heart failure and things like that. So there aren't only just reimbursement barriers to patient care, providing patient care remotely. There's a lot of artificial barriers, as she mentioned, originating site. So until COVID, if my Uncle Wesley needed to see a cardiologist to evaluate something, he had to drive 30 miles to sit in the doctor's office where he could receive a televisit from another doctor that still had to be in the same state of Nebraska, but might be 400 miles away. And that doctor couldn't be at home. That doctor had to be in his office. And so compare that to now, it's that, he uses my aunt's Apple iPhone and connects directly to the doctor who is in his home office. And Dr. Morgan was the first to point it out, and then Dr. Liu echoed it. It's that we don't have a lot of these times to wait. Healthcare is a matter of speed, and it's very important. So I think that what we're seeing is that it's opening up from the demand side, from the patient side, and we're seeing that it's opening up from the provider side, and eliminating those barriers has been fantastic. And I think it'll be hard to put that toothpaste back in the tube.
That's a great segue. That's a great point, Matt. Talking about telemedicine and the patient experience. So COVID has sort of forced the hand, if you will, pushing telemedicine into the spotlight. And that's allowing patients who might not otherwise have experienced telemedicine to experience it. So how do you think this will change patient-driven demand for these types of services? And I know, Jane, you had a story of a recent experience with telemedicine. Can you tell us about that and give us your perspective?
Yeah, I think it's pretty clear that telemedicine is here to stay. And if COVID-19 has done anything, it has accelerated our venture into telemedicine. Currently, physicians are receiving full reimbursement per the emergency use authorization for hospital visits that are via telemedicine. And there's a push to continue to have that happen. I think, as you can imagine, there are still patients and people who are reticent to come into the hospital to see physicians, and physicians as well are cautious about having crowded waiting rooms. And so I think telemedicine has come onto the screen in a big debut. And how it's going to settle out has yet to be seen, but certainly it will be here to stay in a very, very useful tool. I did have my first telemedicine visit with my primary care physician 2 weeks ago after I injured my leg at home, as you can imagine. Most injuries occur in the home. And I had my first telemedicine visit with my primary care physician, and it's clear that it can be very, very effective. Communication can be effective. For once, one of the complaints of patients has been that physicians have been staring at their computer screens, documenting while the patient is sitting behind them or to the side of them, and they're busy documenting. Well, now the patient has figured out how to get the doctor's attention because the patient is on the computer screen that the doctor is typing into. And so suddenly the patient is now back in front of the physician. And I think that was an unintended positive, but there you are. The patient is back in front of the doctor because the patient is now on the screen that the doctor has been looking at and documenting. And so it's certainly here to stay. How it will level out will certainly be very influenced by reimbursement factors and coding. And so we certainly are watching that very carefully.
Thank you, Jane. And I think, Steve, you've had a recent experience. It's interesting to get the clinician experience with telemedicine as a patient. So, Steve, I think you briefly.
Right. I'm a vendor, a patient, and a provider. It was convenient. I'm a fairly healthy guy. No driving, no waiting in the waiting room. My physician was late from that call with the guy with the MI, but it wasn't a big deal. I just did some emails, and it was very convenient. So I do think that Matt said the toothpaste out of the tube. It's definitely out, and the PCP, my PCP, said it was actually helpful. He was saying that probably 20, 25, 30% of his future will probably involve telemed. There are a lot of patients that he doesn't need to see physically, but does need to check in on. That this is a perfect medium for it. I think coming from my world of the acute and subacute world, the telemedicine's being kind of pulled in by the patients and actually being pushed by the providers in a different way than just the ambulatory visits. If you think about when people are discharged from the hospital, there's this really kind of scary window where they're out of the hospital and waiting 2, 3, 4 weeks before their PCP visit. And that's the scary window. And that's where people kind of fall through the cracks and then bounce back and get sick again and get readmitted to the hospital. And what we're seeing is a lot of our providers on the inpatient setting are actually following the patient out of the hospital and kind of having a warm handoff and touch points before they get to the PCP. And we're actually also seeing the PCPs, rather than waiting weeks before they actually see the patient physically, reach out and start to kind of pick that patient up after a discharge weeks beforehand. So you're sort of seeing kind of the inpatient, outpatient, as well as the patient kind of conglomerating and using this sort of new technology to fill sort of a care gap. Cool stuff.
Yeah, it is cool. Thanks, Steve. And to shift gears here a little bit before we do our audience poll, I'm an optimist, so I like to look at the good stories coming out. And recently there have been many stories of unlikely collaborators working together. This isn't quite exactly on this topic, but I think it's important to, I think it's really interesting to discuss some of the local collaborations we've had to address, for example, some of the shortages issues we've had of PPE, ventilators, and even pharma collaborating on drug discoveries. Jane, I know Piedmont has had some inspiring stories of collaboration. Would you mind sharing a couple of those with us?
Yeah, sure. To quickly address the need for face shields, we collaborated with the Global Center for Medical Innovation. We're able to get those designed and 3D printed. And also, we were the first to meet the EUA, Emergency Use Authorization of the FDA, for the shields to not only cover the front of the face, but to come all the way around the side of the face and cover the ears. We had about 4,000 of those that were eventually delivered to our distribution center. And all of that was with the collaboration with GCMI, the Global Center for Medical Innovation. We also collaborated very effectively with Georgia Tech to build intubation cubes, and these are sort of plexiglass-like containers that go over the head and torso of the patient, such that anyone intubating the patient has an additional barrier between themselves and a patient who may have a high viral load, to decrease that risk of infection and provide safety to our staff, which was of paramount concern to us then and still is. And those were arrangements that happened very quickly. Georgia Tech was able to receive a grant to build them for us. And so even that coordination of the grant, with AFLAC donating money, with Delta Airlines coming into the picture, we were able to quickly mobilize and address the needs of our hospital via creative ways for PPE.
That's awesome. I love to hear stories like that, where people really rather rally together and break down some of the barriers. So I think we're going to do the audience poll right now. Maurice, if you want to put up the audience poll, and I believe it should pop up on your screen. There we go. So I'll read them for you. We talked about deferring medical treatment. Have you deferred getting any medical treatment for anything because of COVID-19? So you can answer yes or no there. We mentioned the telemedicine, and I mentioned earlier that telemedicine is one of the tools that is used for chronic disease management. Have you experienced a telemedicine appointment recently, or have one scheduled in the near future? So we want to see the prevalence of telemedicine visits now that COVID-19 is here, just from our audience. So I believe we'll be able to, I'm going to vote myself too. There we go. And I think Maurice will be.
Yeah, we see some. I see some good votes still coming in. So go ahead and participate if you can.
Okay, great. And while you're answering those questions, I'll go ahead and move on a little bit, because we have a lot to cover here. But we talked about the financial implications, and really, I think we had on an important. You had an important point, Steve, when we were having our discussion before. You mentioned on our planning call that COVID has really accelerated value-based care and the drive to lower cost settings of care, which is really, again, chronic disease management is it's kind of been the goal of chronic disease management, to keep the patients out of the hospital, so in lower cost, lower settings of care. Can you tell us about that a little bit? How COVID-19 is kind of driving that?
Yeah, no, it's interesting. I think a lot of our clients, sort of the value-based drivers, have kind of gone into a little bit of a limbo state. They'll come back, I'm sure, but orgs are kind of hunkering down on sort of the basics. Revenue is a big one. We were talking on the call, prep call earlier, but hospitals are now kind of thinking about kind of rebooting things. I think with sort of that bad good analogy, despite like the horrible cost to human life and our impact on our economy, one of the interesting things about this is that COVID may have taken us in a time machine 5-10 years ahead of where we were from a value-based drive. Because if you think about it, in sort of the value-based world, it's all about high quality, low cost with patient sat, right? So that's reducing hospital bed days, avoidable bed days, reducing readmissions, unnecessary procedures, getting patients to be in lower cost sites of care. And, the home is one of the lowest costs, right? So, who would have guessed instantly overnight, each of those metrics got hit. And so I'd be curious, when all is said and done and the analysis happens, what the actual cost of care per member or per patient in the U.S. actually became. But my guess is that it dramatically dropped. Who knows? That might have completely been wiped out by the balance of people who delayed care and have lifelong clinical costly consequences as well. Only time will tell, but it's a fascinating thing that just happened.
Yeah, and that's a good point. Talking about the reimbursement, and Jane, when we were talking, you mentioned that telemedicine is, and maybe this gets to Steve's point about on balance, is not an attractive option if the hospitals and providers can't charge full price. What have you seen on the reimbursement front as far as telemedicine and what you're able to charge?
Right, and so maybe it's not a matter of not being able to charge full price, but certainly the rates would need to be negotiated. And currently, we are being reimbursed for the full visit. What that looks like in the future is yet to be determined, but I think certainly reimbursements will factor into how telemedicine is managed with all physician practices going forward.
Great. I'm going to shift a little bit here now to digital tool adoption. So we talked about the landscape, we talked about the financial implications, and now the adoption of these tools. So given everything we talked about, the landscape has changed. How has that affected the calculation of the utility of these chronic disease management tools? In other words, what have people realized or confirmed that changes the value calculation for using these tools? Matt, I'll throw that one to you.
Yeah, thank you. It's had an enormous impact in our market, and Chronic Care IQ helps physicians keep tabs on chronic and fragile patients from Hawaii to Maine, tens of thousands of them with millions of data sets every month. So what we have seen is that physicians are more willing to adopt it and patients are more willing to accept it, meaning that they are much more engaged digitally. The value of the service is combined now in tandem with the recognition of, if I'm feeling better, I'm doing better, I don't have to go into the office, I am maintaining my chronic disease. And that has a huge impact on our economy because more than two-thirds of our $1 trillion health spend in America is on chronic disease. Chronic diseases are medical conditions that can't be cured, so they have to be controlled. And it's very difficult for a patient to care for themselves. I know when I left the hospital, I got 2 prescriptions and a pep talk. And the physicians go to school for 10 years. They're the best of the brightest. They have the most discipline and the most ferocious work ethics. And our current healthcare system kind of separates us unintentionally from those doctors. So these tools have been around for a little while. They're gaining prominence, but COVID really knocked the door down to the patient resistance, I think, for using them and the physician resistance for considering them.
Awesome. That's good insight. Lucy, your thoughts on this?
Yeah, I mean, I think in terms of, adoption of the tools, this is to Jane, Steve's points, right? A lot of this does unfortunately hinge on reimbursement. And, a lot of folks now are talking about like, what's the long-term impact? Have we fast forwarded 10 years, as was said? And I think one area to really think about that, right, is chronic disease management. Everybody is, talked about primary care being the quarterback of, patient care in terms of these chronic diseases. But until we sort of provided adequate reimbursement for primary care doctors to do that work, it was really hard, right? If they weren't getting paid for any of the sort of between work other than in, quality payment models where maybe their health system in general earned a bonus. So I think that's been the major game changer, has been removing some of the near-term barriers like co-pays that patients have to pay for remote patient monitoring or telemedicine, barriers like you can only onboard a patient to remote monitoring who you have an established relationship with and it has to be done in person. Like we've fixed a lot of that temporarily, and it's been this amazing real-time experiment of, like if we fix some of these, if we take away some of that friction that we've all known within the system, both the patients and the providers can really do this. What are the long-term implications for the business model for primary care to be that quarterback and sort of get paid to do that work of a continuous model of care management? And, I think the utility of the tools, one thing we're hearing a lot is we're talking with health systems both about chronic disease management, and then we've been doing work around monitoring and screening COVID patients who are high risk, right, who have these chronic diseases, and what if they get COVID too? is, we can really, through technology, start to drive a lot of efficiency around that, of, a nursing team that can manage a much bigger population of patients if you're providing some automation. So, we've got to all share those stories. We've got to collectively learn. We're publishing that work right now in JMIR just to get it out there. Like, these chronic disease patients still need their, hypertension meds and their diabetes meds when they're quarantining for COVID, and maybe they don't have anybody who can go get that medicine for them. So, let's fix that problem instead of having that individual have a complication of diabetes or a cardiac event just because we're telling them to quarantine because they have COVID, right? It's all interrelated.
Yeah. Yeah, those are good points. It's sort of stripping back all the fluff and saying you're getting to the heart of this and really showing the value of these tools. And I want to get to the audience Q&A. So I would love to, but we don't have time, talk about Matt's patient experience as a chronic disease patient. Really interesting story there. But I'm just going to wrap up our discussion before we get to the audience Q&A with a sort of, I'll go around to each of you and ask, we mentioned toothpaste changes earlier. In other words, something that's done, you can't undo it once the toothpaste is out of the tube. It can't be put back in. So I'd like to ask each one of you, and I'll go around in alphabetical order again, to tell me one toothpaste change you think, or maybe hope, won't be rolled back, whether it's reimbursement, financial, regulatory, or this doctor-patient experience, or maybe some of the collaboration you're seeing. So Matt, let's start with you. What's a toothpaste change that you'd like to see stay?
Yeah, if I could, I'd love to elaborate on all of the above, but I think if I had to say one, the toothpaste is out of the tube, is that patients understand now that their access to care doesn't necessarily depend on getting in the car, driving a ways to getting a visit, finding a place to park, waiting in the office, being roomed, waiting for the doctor, seeing the doctor for 10 minutes, getting rushed out of the room, and going home and still having questions. That there will be a more persistent and patient-friendly way for them to receive care that might not involve a visit to the office.
That's great. It reminds me of sending an email versus sending a written letter, right? You got to write the letter, put it in an envelope, put a stamp on it, put it in the mailbox. So versus typing up an email. So that shift in convenience is something that's going to be hard for people to go back on. Lucy, how about you?
I think probably the reimbursement aspect is, been a really meaningful part of this change, and that's what I really don't want to see go away, are these small tweaks to reimbursement models that have been very meaningful to the physician practices to make this a viable method of care delivery.
Excellent. Yeah, I'm a big fan of the reimbursement shifting too, obviously. Steve, how about you?
Mine's kind of interesting. When we deal with a lot of clients, especially the more complex health systems, they're fragmented, a little siloed sometimes, and we've seen COVID, kind of break down those walls between organizations within these organizations and these health systems and practices even. So and they're working together. They're moving physicians and providers across state lines as a unit as opposed to separate entities. So from a provider standpoint, I loved seeing that for our clients, and I do hope that stays, and I think it will.
Excellent. Jane, how about you?
Yeah, and I echo everyone. I have a couple of them, certainly from an innovation perspective. This COVID-19 has shown hospitals to sort of be all hands on deck, different employees deployed to different roles, people coming up with different ways of doing things that are effective, bringing them to the innovation program, implementing them within their departments that turned out to be better practices for the patients as well. I think people were willing to step up and step into those gaps and bring their ideas forward. And I think that has done a lot to push innovation forward and for people to understand how they can be a part of it and how it can be effective. I think the other thing that maybe has yet to be seen that I ponder is whether infection control in hospitals has actually improved with COVID-19 as people have been more fastidious with the hand washing and the hand sanitizer and being in isolation gowns when we're changing lines, and whether or not when all of this is said and done, that turns out to have decreased infection rates in hospitals. I don't know if that's true, but I'm anxious to sort of look at that data to find out if that has been a positive byproduct of protecting our staff in managing COVID patients. We actually have an understanding of how it's gone further to decrease our infection rates, as people have been incredibly fastidious with hand washing and face masks.
That's interesting. I haven't, sort of everybody's focused on that now. So hopefully that stays a remnant of this pandemic. So I'm going to turn now to the audience Q&A. So I'm going to turn to some questions there. First one, I think Lucy mentioned using these somebody using these chronic disease management tools, these telemedicine and remote medicine, however you want to define it, in the acute care settings. And I know, Steve, when we were having our panel discussion beforehand, or our prep calls, you mentioned using some of these digital tools in acute care settings. Can you give us some examples of that and how COVID-19 has impacted the use of some of these tools, even in acute care settings?
Yeah. You know, when we talk about acute care, you don't really expect telemedicine in the acute care setting, and we've seen spots within our client base, but then even my own practice last week started to use it. But you know, a COVID patient in their COVID room is a black box. I mean, it's so much work to go into that room just to ask a question. You know, the amount of PPE usage that gets literally thrown away after 5 minutes is a huge amount. So folks are starting to use telemedicine for that to limit on PPE usage, obviously limit exposure of providers to the clinical patient who's got COVID. It's interesting, when we're doing a code on a patient, you actually literally have a team in the room, and then outside the room there's a separate team, and those walls are thick because of x-rays and whatnot, and so you can't communicate through the glass window. And so just being able to telemed and talk to each other from 1 inch away is actually really important. And that what we're seeing also with the clients is they actually have providers who are stuck at home. They caught COVID, they're convalescing at home, they're completely doing fine, but they can't work. And so they're actually leveraging it to have those physicians do things remotely with the patients as well. So interesting in that it's made its way into the acute care setting as well.
Yeah, and so that the next question kind of relates to that a little bit, in that how will the changes, I think I'm skipping one, but anyway, how will the changes to the reimbursement landscape affect how hospitals operate? And this is sort of tied to a question that I had queued up that I didn't get to, and I'll sort of expand on that a little bit and ask, related to how hospitals operate. Jane, you had mentioned that hospital volumes are down and people are deferring care and sort of using these remote tools. Do you think this is something here to stay? Do you think hospital volumes are going to remain down? Will telemedicine help reduce hospital volumes?
Yeah, I think what we're going to see is a shift in the type of patient that's in the hospital. Patients with more chronic diseases and or patients with acute episodes. But I think, ultimately the hospital is still here. It's going to be here for all patients who need overnight intensive care. I think telemedicine, though, will shift that. And hopefully, as I look out into the future, fewer patients will require hospitalization for some of these tools that the people here on the panel have developed. And patients can be managed at home and therefore have better control and better management of their chronic conditions, keeping them out of the hospital, whereas before it was difficult to have access back and forth to the physician. Now they have a more seamless means of communication, and hopefully, it's yet to be seen, we'll see decreased hospitalization and better chronic care management over time.
Yeah, so the efficiency, the really will come to see fruition, the value proposition that these tools have been built for, really. Mm-hmm. So the next question, one of the questions here is really interesting. I'm always curious about this because I hear this with these various technologies, maybe I'll let you guys decide who wants to answer it, but what are the liability implications of telemedicine for doctors and hospitals? So will that introduce some liability to the doctors? For example, I know that if you have a remote monitoring tool and it sends a notification at 2 a.m, I mean, who's responsible for managing that? So I think that's always an interesting question now that all this data is coming in, all this tsunami of data. What is that? What are the liability implications? Is there some concern about that? I don't know, maybe Jane or Steve, either of you want to talk about this one?
I can take a stab at it, Jane. I'd be curious to see your thoughts as well. Like, COVID kind of really helped maybe the defensive way of practicing medicine, sort of like the Good Samaritan law where, it's all for the good of the nation, don't worry about that. It's all about taking care of patients, saving lives. And so that put the spotlight on sort of, what I became a physician for. I'm sure Jane and, all the other physicians on the call we became physicians to save lives, to take care of patients. And so that's the really nice thing about it. I do worry that once this is done with, and then you go back into the old rigmarole and the old worries. If you think about the way medicine was practiced before, a large amount of cost was just defensive medicine, tests that didn't really need to be done, but you got to do it because you don't want to be sued and malpractice and all that sort of stuff. I'll just say I hope that doesn't become a problem or something I have to also think about. I don't know if Jane, yourself, and feel the same with the defensive part of it.
Right. Yeah, it seems that liability will shift and be fluid as well, and will be an active occurrence as we continue to work through that. Certainly when we look at these reimbursement models and the way healthcare will be delivered in the future, liability will be an active part of that conversation.
Awesome.
And Richard, I'm happy to.
Yeah, Lucy, I'd love to hear you.
I can briefly weigh in on that. Yeah. I think what we have found, because we've had this conversation pre-COVID with a lot of practices, right? If they're remotely monitoring biometrics of a patient, blood glucose, what do I do if that patient has a 32 blood glucose in the middle of the night? Is that on me to respond? And I think there's going to be a need, there has been, and will going forward be this need for sort of clarity of expectations. When practices, they are now reimbursed for onboarding a patient to a remote patient monitoring technology like blood glucose, and setting the expectation, right? That instead of you writing your numbers in a book and bringing them to me every month, and if you had a 32 in the middle of the night, that's what you learned about in patient education for diabetes, is how to deal with that at home in the moment, right? That's the medical emergency that you need to deal with. And that doesn't change, right? And it's sort of this more convenient way of sharing technology and or sharing data and updating care plans, but it is not a real-time monitoring system. And so I think that distinction is really important. And when we get into conversations about liability with practices, one, those seem to have decreased over the past several years as people get more comfortable. And two, I think it's really important that the practice and the patient have a clear understanding of what these telemedicine or remote monitoring technologies are for and what they're not for.
Great. Yeah, I totally agree. Setting expectations is key. And we're up against the end here, so I want to turn this over to the chair of TAG Digital Health, Chris Carabinos, and he's going to tell us about some upcoming events. And before I do that, I want to say thank you, panel. This has been a great discussion, and thank you so much. Chris?
Thank you, Richard, and thank you, panel. What a great conversation here. I took a lot of notes myself, so And in case you're a first timer here, will be recorded and put on the tag site, so you can go back and listen to it and share it with your friends and family and your kids. Just want to give you an update. We have had a number of events this year. This is our fourth one already, as you can tell, through today. We have one coming up in June and a number of others. And I just want to a couple of things here. The June one, the date hasn't been set yet, but it's going to be around healthcare data exchange during a pandemic. Who has the latest data? How's it feeding from the state to the federal? Exchanging information. There's been a bit of maybe an information war going on. And so we're going to have Dr. Kathleen Toomey she's the state of Georgia's health commissioner. She's agreed to be on with us. And we also have Dr. Amy Gleason, who's with the United States Digital Service in Washington, D.C. She works on Dr. Brooks' staff that you have seen on the daily, previously daily press conferences. So we've got a couple of stars and a couple of other people. It's going to be a great panel. So look for information about that too. And that too will be a virtual lunch. The events after that, we hope will be in person, but we don't know. And we're also planning to make all of our events going forward. We'd like to make them a live stream. Even if they are in person, we'll try to make them, now that we've discovered Zoom and discovered how convenient this is for so many folks, we'd like to do that. But the July 30th and October 28th events, those two are tied together for the Georgia Healthcare Innovation Challenge. So we're partnering with Georgia HIMSS and ATV, as well as Atrium Navicent Health, in two challenges that they have some healthcare technology problems that they cannot find solutions for. So we are inviting companies, whether startups or mature companies, to come listen to their two pitches, and make proposals about how to solve that. And they'll pick one winner from each of those two challenges on October 28th to go right into a beta test and go test those things. So that's going to be a pretty innovative way to partner between the technology community as well as the provider community. And also, we're partnering with TAG Corporate Development on August 5th around digital health investments in a COVID-19 world. That world's been turned upside down too. So we're looking forward to really active pitch there. And I'll skip down November. We don't have a date yet, but it'll be the third week in November. We're going to have our digital health summit, but it will be virtual this year. So we decided instead of trying to pivot in late fall, we're just going to make it virtual, and details will be coming for that one. And on the next page, Richard, we are aware of one other healthcare technology event this month, and that's with Georgia HIMSS. They have a lunch and learn around cybersecurity and healthcare. My guess is that'll probably be virtual too, but you can go to their site and learn more about that. Thank you again, panel. Wonderful job with that. Richard, wonderful job organizing it and leading the conversation. Maurice, appreciate everything you've done in the entire committee. So wonderful job, guys. Thanks a lot. And look for future emails from us. Take care.
Thanks, everyone.
Yeah.
Thanks, everyone.